Okay, so this case is a young kid who's we chose the appliance Invisalign first, which are clear aligners made for mixed dentition. And he had a unilateral posterior crossbite with lack of space for upper laterals. So the kid presented at the age of 8 years of age, and you can see here that he's got very little space for his upper lateral incisors. He's also got a unilateral posterior crossbite, but actually there's a functional shift, so it truly is bilateral, and slightly narrowed maxilla. Now, when you see long face, strained lips, possibly lip incompetence, you start thinking sleep disorder breathing, slightly narrow maxilla. We know that many kids with a narrow maxilla tend to have sleep disorder breathing symptoms. So obviously this is something you need to be aware of. Now, on further questioning, clinical history, as well as radiographic examination, it didn't seem that he had that. So skeletal expansion of the maxilla wasn't as big a priority as dental expansion and correction of the functional shift. So our objectives were to eliminate the functional shift, number one, and crossbite, to then create space for upper lateral incisors that needed to erupt, and then to monitor his growth for later treatment if needed. We think this could have been done in 12 months, and depending on whatever treatment appliance you choose. Looking at the OPG, you can see here that his lateral incisors are already turning to 90 degrees prior to eruption. They're pretty turned, okay, they're 90 degrees. So why is that happening? Because there's lack of space. So just provision of space should hopefully allow them to drop and maybe even self-correct, or we can guide them into the right position. It will probably prevent some impaction of canines or ectopic eruption. And not only that, there's possibly loss of some space because of early loss of certain teeth, or in this case, it could be just a narrow maxilla. Now, when we look at his cephalometrics, even though he moved, and this is not diagnostic for skeletal occlusion or dental occlusion, you can actually see the airway really clearly. And what you see is, yeah, there is a slight adenoidal mass, and you can kind of see this adenoidal mass right there. It's right on the posterior wall of the nasopharynx, but it's not really that enlarged. You still have a lot of shadow in this area, so it's still quite patent. And there is, again, if you saw tonsillar mass, you'd see it projecting here, and we don't see a tonsillar mass there. So we're seeing quite an open nasopharynx and oropharynx. So it's really unlikely that this kid would be having sleep disorder breathing symptoms unless he had a lot of allergies or other issues. So anyways, we basically decide to question. There's no snoring on regular basis. So we decide to just simply really focus on correcting this functional shift and creating space for the upper lateral incisors to drop down. And when you look at this crossbite here, you see he's got a functional shift. The moment we get the center lines aligned, we're seeing a bilateral crossbite. And the maxilla doesn't look as narrow as you would expect, right? It just looks edge to edge kind of position to mandible in the transverse dimension. So I really think dental as well as dental alveolar expansion is pretty good here. Now, why I say dental alveolar? Because when you move teeth, especially in a growing child, you also move the dental alveolus somewhat, okay? So you're getting some sort of widening of the maxilla, and there's already some transverse growth happening here. So we decide on clear aligners only with the class 2 elastics at night, more on one side, the right side, then the left, and recreate his simulation. So obviously the upper midline was a bit off, so that's moving. We're distalizing upper right posterior teeth. And if you notice in children, I distalize as a group en masse rather than sequential. And we're using class 2 elastic to support it. You can see the side views here. Very little attachments. There's hardly any attachments there because I actually don't really use a lot in children. One of the issues with children is you might find you do a lot of refinements. So when you look at this kid, he comes back 2 months in treatment on aligner 8 or something like that. and they're not fitting anymore. And that's because his upper right lateral incisor, the 1-2, has just started erupting, and it was unerupted before. So it erupted so fast by us creating space that even though we're estimating that this would take a while, it actually happened really quickly. And hence the aligners don't fit. So we actually took a scan again and got new aligners made, and gave him a temporary S6 type retainer just to hold the teeth in this position. So we tell the technician pretty much post the same clean check. We don't want any changes, keep the same attachments. We're not going to remove them again, continue all the corrections we had. So we get another clean check 2 months later, 2 months later into treatment. We continue the same movements, those quadrant 1, group distalization, and moving the 1-2-2-2 forwards, creating space. We are creating a lot of space to help them erupt and guide them into straight positions. Do you remember the OPG? They were turned 90 degrees. So these are the side views, just showing you distalization again, and that's what we're planning to do, to finish in a class 1 molar as close as possible on that right side. It was class 2. And this is the kid 9 months progress. And again, facially, he's the same. There's been no changes. If anything, his lower jaw has projected a bit more anteriorly. His chin projection is a little bit better. And I think that's just natural growth of his chin area. So we are now almost fitting the upper lateral incisors. They are no longer rotated, they're straight. And the plastic was able to guide them into that position. So it's guided eruption. And then we have midlines almost meeting now. The crossbite literally resolved. The palatal vault's looking good. The arch forms are looking good. But we just wanted to overcorrect the expansion because we know 30% of expansion has a relapse. So as we overcorrect, we basically just ask our technician to continue that distalization and buccal movement of the quadrant 1. And we are basically just aligning the front 4 teeth a little bit better. Bear in mind, if you understand growth and how teeth erupt in a child, you often don't need attachments for extrusion. I know I'm saying that because you've always heard extrusion, attachment, very unpredictable. But in a growing child, and you see this case here, in a growing child, the teeth will just erupt if you give them space. There's dental-alveolus eruption, and it's quite significant that you don't even need attachment. So you can see there's no attachments here being placed palatally or labially. The teeth have erupted right into the positions. We've got the upper 6 out of crossbite now. And even though the upper D and E's are still leaning in, we have leeway space of Nance. C, D's, and E's are still present in all quadrants. And, now we just do a finish scan, meaning we're going to give him some retainers now. And one thing you can do, you can use your Invisalign lab to create you some passive aligners. So here, I just, you can't retain mixed dentition for a very long time because they have teeth erupting. So what I want to do is just maintain the expansion. So I basically asked my technician to keep all the attachments, whatever they are, just give me some passive aligners. It's just going to hold the expansion we've done. The patient might wear each aligner for a couple of weeks. So 8 aligners might take, 4 months, 3 months, they might lose some aligners. No further movement required. And he only wears it at night now. These are retainer type aligners. They're passive. There's no more active movement. So Invisalign sends us this movie with nothing moving. And that's exactly what we want. So if he has a bit of relapse, just by putting his aligners on every night, they go back. So we're holding it in this way. And finally, when the 8 aligners finish, the passive aligners, he comes into our office. We take his final records, 14 months from the day he started his treatment with us. And you can see the crossbite corrections holding up. He's pretty much class 1 as well. He was a full unit class 2 on the right side. Now he's class 1. We've got nice eruption of all his incisors. Leeway space of Nance is still maintained. There's no early mobility or loss of teeth. That's his OPG. We can see the canines are all in a very favorable position to erupt in the future. We still have leeway space of Nance in all quadrants. So, very unlikely this kid might need a future comprehensive phase. But if he does, hopefully it'll be fairly simple and easy for him. If we hadn't done any early treatment, the crossbites are seldomly self-correcting. The functional shift is seldomly self-correcting. So we could have created a more asymmetric phase, asymmetric occlusion, if we hadn't done any interceptive work. So you must explain to the patient the risks and benefits of no treatment and risks and benefits of treatment. So what we have here is a screenshot of his dental monitoring portal. And in our practice, everybody takes a virtual 3D scan using dental monitoring every week, and they do not change their aligners until we tell them to. So the green dots means we've said change, change, change. Red means don't change, don't change, don't change. So this kid is every week taking these scans. We teach the children how to do it themselves. Sometimes the parents will help. It takes 2 to 5 minutes. They're very compliant. A majority of our cases on dental monitoring are very compliant. And what you see here is the changes as things are going along. We have multiple views. We can see the videos themselves. And we can see, things like oral hygiene, any caries, any loss of attachments, any buttons, any treatment not moving to the goal, aligner misfits. There's a lot of things that you're looking at in this one shot of photos. And you're seeing a really nice treatment progression with multiple different angles with aligners and without. So the patient has to take a video with aligners and one without. So here he is, finally finished at 14 months. His midline's coincident, crossbites resolved, maxillary vault shape and arch is pretty good. He doesn't have any sleep disorder breathing. He's not an open bite so far. Now, growing forward, he looks a bit vertical. He might have more vertical growth of his jaws. Now, that is something that might happen, but he doesn't have an open bite. So there is no need for any further treatment, but just some growth development checks, maybe every 9 to 12 months until full permanent dentition is confirmed and it's erupted. So guys, thank you for watching me. I hope you enjoyed this case. And if you want, you can ask me questions in the comments below. I'll also post this on YouTube. And if you want to learn more about clear aligners, you know that I'm a lecturer for Best Orthodontic Seminars and Sessions, where we have accredited postgraduate diploma, Australian and UK accredited, 100% online with a lot of one-on-one interactions with me. And, we teach people how to do clear aligners efficiently and effectively and with managing risks really well. So just let me know if you have any questions, and I look forward to one day talking to you. Bye.